Nursing exams don't care if you can recite the dictionary definition of a disease. They want to know if you can look at a patient's chart, filter through a dozen different symptoms, and identify exactly what is actively killing them right now. To do that, you have to separate expected, non-lethal symptoms from critical complications. You have to look past the obvious distractions to find the lethal anomaly. This chart outlines your clinical baselines. Osteoarthritis is localized wear and tear. Cartilage breaks down and pain worsens with activity. Rheumatoid arthritis is an autoimmune attack. Your body targets its joints, causing systemic inflammation, symmetrical pain, and prolonged morning stiffness. Then you have systemic lupus erythematosus, or SLE. This is an aggressive autoimmune disease that attacks connective tissues and major organs indiscriminately. Localized pain requires mobility management. Systemic attacks threaten vital organs and demand immediate, high-level clinical intervention. Let's apply this to a patient scenario. You have a 30-year-old female with lupus complaining of severe joint pain and fatigue. She also displays a prominent malar butterfly rash across her face. But look deeper into her chart. She has an output of only 200 milliliters of dark urine over the last 12 hours, and her lab results show elevated BUN and creatinine. Which of these is your immediate concern? The painful rash, the stiff joints, or the low urine output? The rash and joint pain are expected with lupus, but low urine output combined with elevated BUN and creatinine indicates lupus nephritis. Her kidneys are failing. This complication is the leading cause of death for SLE patients, and it supersedes any skin or joint issues. Allowing a classic, highly visible symptom to distract you from silent organ failure is a fatal clinical error. Cancer is characterized by uncontrollable cell growth. Because of this, the treatments of cancer and severe autoimmune diseases actually share a dangerous mechanism. Both chemotherapy and medications like DMARDs indiscriminately kill fast-growing cells. This means patients on either treatment share the exact same critical nursing priority: bone marrow suppression. Bone marrow suppression creates three massive system failures: anemia from low red blood cells, thrombocytopenia, which means low platelets and a high bleeding risk, and neutropenia, a dangerous drop in white blood cells. Here is your second scenario. A post-chemo patient reports severe fatigue, displays bruising on their arms, and has a recorded temperature of 100.4 degrees Fahrenheit. What is your emergency? The fatigue from anemia and the bruising from thrombocytopenia are serious, but a fever of 100.4 in a patient with no white blood cells means neutropenia. That is a massive, immediate medical emergency. They have no immune system to fight the infection that is starting. You must instantly institute strict neutropenic precautions, secure a private room, remove sources of bacteria like raw foods or plants, obtain blood cultures, and administer prescribed antibiotics. In severe systemic disorders, the harsh treatments meant to save the patient often create their most lethal vulnerabilities. Success on the NCLEX comes down to distinguishing the expected manifestations of a disease from its lethal complications. Let's lock this in with an ultimate priority matrix. For musculoskeletal and immune disorders, osteoarthritis requires managing pain and mobility. Rheumatoid arthritis requires controlling systemic inflammation. With lupus, you must protect the kidneys. For oncological emergencies and bone marrow suppression, anemia requires oxygen and rest. Thrombocytopenia demands strict bleeding precautions. Neutropenia requires immediate infection control. It is your absolute highest priority. Grab a screenshot of this matrix to use as a study guide for your exams. Always remember, protecting vital organs and preventing fatal infections will always supersede managing chronic pain.